guys, Hematology Summary. Let's first talk about the RBCs. You need to understand that anemia is a word made up of two terms. A means no, and emia for blood, no blood. And it simply means that the number of the RBCs is decreased or they are abnormal, because if that's the case, oxygen delivery to tissue, which is the sole job of RBCs, is insufficient, and it's going to be a problem. Patient will be tired at the very least. When can you have decreased number of red blood cells? Well, worst case scenario, there is a severe blood loss such as hemorrhage, motor vehicle accident. We call it acute anemia, happening right here and right now. If a patient bleeds a lot, number of red blood cells is going to be down. Patient may also lose red blood cells within the blood vessels, and we'll see how that happens. So in case of bleeding, hemorrhage, motor vehicle accidents, trauma is a serious case. Worst case scenario, we'll have a shock where the patient has signs and symptoms of shock, cold, clammy skin with profuse sweating. We call it diaphoresis. That kind of a shock due to blood loss is called hemorrhagic. Hemo meaning what? Blood. And ragein is a flow. So patient is bleeding, losing a lot of blood, and developed shock. How much is a lot of blood? 1.5 to 2 liters. I usually walk around with a 1.5 liter bottle just for your understanding. That's about 30 to 40% of blood, of the total blood within the body. Obviously, that causes decreased volume, hypovolemic shock. Hemorrhagic shock leads to hemorrhagic shock is essentially a type of a hypovolemic shock. When the blood volume is low, patient's heart cardia starts beating very fast, tachycardia. Patient's blood pressure is severely reduced. You can't even feel the radial pulse, and we call reduced blood pressure hypotension. Worst case scenario, patient will lose consciousness and possibly die. Now, do understand that anemia associations with increased risk of falling, that's pretty much, to say it nicely, results are inconsistent. In 2022, we don't really think that's the case. Now, I did mention that blood loss due to motor vehicle accident is hemorrhage. Blood loss due to hemolysis within the blood vessels. An example for that would be autoimmune diseases or malaria. Malaria is a parasitic infection that doesn't really happen in the US very much. We see very few imported cases here, but that parasite gets into the red blood cells and destroys them from inside. So obviously what we see are signs of hemolysis. Most common cause of anemia due to deficiency of minerals or enzymes is the iron deficiency anemia. Think ladies who are menstruating more than their body can tolerate, or more often, metrorrhagia more often, bleeding more often than it should to maintain the homeostasis. Menorrhagia, bleeding is heavier than is necessary for homeostasis. GI bleeding is distant second. Don't forget that half of the population is menstruating every month. So iron deficiency anemia, always suspect iron deficiency anemia in a menstruating female. Gastrointestinal bleeding, an elderly male or female. Drug side effects, rare but possible. What happens if there is chronic blood loss, such as in one of these three? Then patient cannot make sufficient proper red blood cells, and patient develops anemia that can be prevented or treated with iron sulfate. The name for iron sulfate is ferrous. How to remember? Ferrous, us, you and I, us. versus ferric. There is ferric iron. You don't want to take that. You want to take what is one of us, ferrous sulfate. Sickle cell anemia is due to a mutation in RBC hemoglobin. You've already seen that in your anatomy and microbiology courses. What happens here is that if you look from above, the RBC is usually round. Now, if you look at a sickle RBC, it looks like a sickle. Sickle is not something that we see daily. Sickle means essentially crescent-shaped RBC, and this conversion happens when RBC is exposed to lack of oxygen, hypoxemia, or conditions in blood where the normal pH, the normal acidity is increased. So blood is very acidic, acidosis, chronic condition with a lot of acid. So what happens then is that these sickle red blood cells stick together. They have the genetic change in a normal RBC such that these sickle cells are a little bit more sticky, and so they cause blood vessel occlusions because they stick together. And this occlusion, similar to any other thrombotic occlusion, can cause severe pain, which should be treated. Always treat your patient's pain right away. Respect patient's pain. It could have been anyone of your own, your family, friends, you yourself. The last anemia that I want to talk about is anemia due to deficiency of vitamin B12. In order to absorb vitamin B12, body needs a product that is made in the stomach, and that product is called intrinsic factor. So stomach makes that intrinsic factor. In pernicious anemia, pernicious means bad, in bad anemia, pernicious anemia, there are autoantibodies, it's an autoimmune disease, that destroys cells that make that intrinsic factor. Those are the parietal cells of the stomach, and so B12 can no longer be absorbed in the ileum. B12 is absolutely important for cell growth and development, so we get a subtype of megaloblastic anemia, megalo, huge cells, red blood cells become very, very huge, called pernicious anemia. Now, compare and contrast anemia, no blood, to polymany-cytcellemia, a lot of red blood cells in blood. So a lot of red blood cells in blood is polycythemia, that's the term. That may happen due to increased number of red blood cells or simply due to a decrease in plasma volume. Plasma is 90% made up of water, so if you decrease the contents in which red blood cells swim, so as to say, it'll look like we have many more red blood cells per certain volume of water than there actually are, even if the number does not change. Increase in red blood cell mass, we call it polycythemia. Now let's talk about the white blood cells. White blood cells, you don't need to know too much. You need to understand that white blood cell in Greek means leukocyte. Leuk, and anytime you have an elevation of white blood cells in blood, elevation of white blood cells in blood, blood in Greek is emia, just like anemia. Now we have leukemia, elevation of white blood cells in blood is called leukemia. This is a little bit of a simplification. In reality, leukemias may long-term present actually with a decreased white blood cell count, but that's for your clinical knowledge. Now, initially and most commonly, leukemias present with an elevation of white blood cells. Elevation of white blood cell can be very chronic over time or very acute, happening right here and right now. This will help you to remember which one is which. Chronos is a Greek word for time. So time, think about an elderly, and think about an adult who is more than 60-year-old. Time, more than, and that's also the most common leukemia in adults. Chronic lymphocytic leukemia, most common in adults. Now, think about a little kid. Children. What is more common in kids? Acute. It happens right here and right now. Leukemia. increased white blood cell count in blood. How do you remember this thing between the difference between lymphocytic versus lymphoblastic? I'll tell you, we're talking about actually lymphocytes. You know that lymphocytes, just as basophils, eosinophils, and neutrophils, lymphocytes are also white blood cells. So in this particular case, we're talking about elevation of lymphocytes in blood, okay? It could have been the other ones, but we're talking about lymphocytes. Now, lymphocytes which are mature are lymphocytes. So chronic, we have mature lymphocytes that are elevated. In children, we have actually B stands for you, B stands for babies. We have an elevation of lymphoblasts. Lymphoblasts are immature baby lymphocytes. So once again, ALL stands for acute lymphoblastic leukemia, which is simply an elevation of white blood cells, namely of the lymphocyte type, which progresses very rapidly and is extremely aggressive. You got to treat it with either chemotherapy or bone marrow transplant. You can do that. And chronic lymphocytic leukemia, CLL, is also an elevation of white blood cells. You see actual adult lymphocytes, not the baby lymphoblasts that you see in children. And it's the most common leukemia in adults who are more than 60-year-old. Now let's compare leukemia. Emia stands for blood, with a lymphoma. Remember, we're talking about throughout all of these four cases, we're talking about lymphocytes. Lymphocytes are white blood cells that are important for immune tolerance. So how do we differentiate lymphomas? Lymphomas should be compared with leukemias. Lymphomas should be compared with leukemias. Lymphomas are tumors of lymphocytic heritage, just like leukemia are blood tumors, blood poisoning, blood cancer of lymphocytic heritage. Lymphomas are actually those lymphocytes that are found in solid organs. What is a solid organ? A spleen, testis, etc. Okay, brain. So lymphoma is a tumor, oma, in some part of the body, and lymph nodes are involved. Okay, so once lymph nodes are involved, we're talking about lymphoma. All right, lymphomas are not differentiated based on chronic, acute. We differentiate them based on whether they are Hodgkin or non-Hodgkin. Hodgkin was a British scientist who lived about 200 years ago, and was the first pathologist who actually described this kind of a lymphoma. And the difference is extremely easy. If you see Reed-Sternberg cells, how would you recognize a cell with such a difficult name, Reed-Sternberg? You look for a cell with owl eyes, two nuclei. So a cell, if you see Reed-Sternberg cell, a cell with owl eye nuclei, that's a Hodgkin lymphoma, period. If you don't see it, that's not a Hodgkin lymphoma, all right? So Reed-Sternberg cell derives from B lymphocytes. There is also a non-Hodgkin lymphoma. That's the other one. That's the comparison. Non-Hodgkin lymphoma derives from any of the three lymphocyte type, and you know them from anatomy. You know that one type is the B cells, so it shares B cells. Reed-Sternberg cells may derive, Hodgkin lymphoma may derive from the B cells, but here we have a possibility of deriving from T cells and the third type of lymphocytic cells, the natural killer cells. Hodgkin versus Hodgkin. Now let's talk about platelets. Remember, another term for platelets, thrombocytes. Thrombocytes equals to platelets, absolutely no difference. What is the job of a thrombocyte? It contributes to hemostasis. It's the first step to stop bleeding. It's a plug, it's a platelet plug that forms and stops bleeding. We have a few diseases you need to know, namely two that have a decrease in platelets. One of them is very easy to remember. It's called immune thrombocytopenic purpura. So thrombocytes is in the name. ITP, immune, stands for it's immunologically based. It usually happens after viral illness. We really don't know why and how immune thrombocytopenic purpura actually develops. We used to call it idiopathic thrombocytopenic purpura. And what does purpura mean? Purpura is the size of bleeding into subcutaneous layer, into skin, that takes place. And with this disease, we see a lot of bleeding that is between 3 and 10 millimeters in size. We call it purpura. 3 to 10. Now, what if the bleeding is smaller, between 1 and 3 millimeters? Sorry, I said centimeters, it's millimeters. 3 to 10 millimeters in size, purpura. What about petechiae? Petechiae is 1 to 3 millimeters, and purpura, it's also the purple color that you get after the bleeding kind of starts improving and patient starts recovering from that bleeding. So immune thrombocytopenic purpura, ITP, follows a viral illness, and you see those bleedings, purpura and petechiae. The other disease that you need to know is called HUS, hemolytic uremic syndrome. That is most common in children and presents with a severe bleeding. Obviously, if the platelet count is low, hemostasis is not possible. You can't stop bleeding, and so the patient bleeds. And because in hemolytic uremic syndrome, it's not only the platelets that are down, also the ability to clot blood, the coagulation factors are down. We have a bleeding from any opening sites, and they also include the wound sites. Due to everything that happens in the hemolytic uremic syndrome, we have acute renal failure that is always diagnosed with it. It's one of the diagnostic criteria for hemolytic uremic syndrome. We're talking about a severe disease. Patients need to be in the emergency room the whole time. Hemolytic uremic syndrome, HUS, also reduction in platelets among. Let's talk about bleeding now, because this is a good segue from thrombocytes to coagulation. You do know that coagulation is different from thrombocytes. Platelets just provide a plug. Clotting is the ability of blood due to clotting factors that are present in it. Let's first see how that happens. So what is a thrombus? Thrombus derives from thrombocytes. It's just a blood clot. Okay. What are risk factors for clotting? If the blood doesn't move, stasis. If the blood has some kind of a disease where it clots very easily, hypercoagulation, and if there is a damage to the blood vessel wall that is in contact with blood. All right, so this inner lining called endothelium, endothelial damage. These are all critically important in development of venous thrombosis. Venous thrombosis. We're talking about the veins here, okay? Thrombus, blood clot. Blood clot formation in a vein. Now, what if this thrombus flies like a ball through the blood vessel? Then we call it an embolus. And if it flies to the lungs, we call it a pulmonary embolus. So a clot, thrombus, that travels to the pulmonary arterial circulation. What will it do there? It will obstruct any of the blood vessels, arterial blood in this case, that will, because pulmonary, the right ventricle, blood passes from the right ventricle through the pulmonary valve to the pulmonary artery and then hits the lungs. It goes to the lungs and would block any blood vessel that it can no longer pass through. Now, before I talk about DVTs and pulmonary emboli a little bit more in detail, I want you to remember that varicose veins, the one that we see on many patients past their 30, 40 years of age, are just abnormally dilated superficial veins. You can see them with your eyes, okay? And they're usually found in legs because that's where blood sometimes pools and pushes apart those veins. It's a vicious cycle where the valves are pushed apart. These veins are not what I'm going to be talking about. I'm going to be talking about the deep veins of the thighs and the pelvic veins that are veins in question. Varicose veins varicose veins are dilation of superficial veins, and they do not predispose to thrombosis that shoots to the lungs, creating pulmonary emboli. Now let's talk about deep venous thrombosis. Deep venous thrombosis are thrombi that form in the deep veins of the thighs and pelvis. What may happen is that they may dislodge, they may start moving toward the lungs, forming a pulmonary embolism. And depending on the size, they can be very deadly. What happens here is that you want to obviously prevent them. How do you prevent them? You prevent them by raising the legs so that blood starts moving. Remember, stasis, remember, endothelial damage and hypercoagulability. So you want to prevent stasis by elevation of the extremities and compression stockings, which move all that blood. The compression stockings and elevation of extremities don't allow blood to pool in the extremities, which are your legs, obviously. You also should and could use anticoagulants depending on the patient's predisposition and particular case. Anticoagulants prevent or treat formation of deep venous thrombi and thrombi in general. Let's see how this happens. There is an enzyme called thrombin. It's an enzyme in blood responsible for converting fibrinogen to fibrin. Fibrinogen, which an enzyme that generates fibrin, fibrinogen to fibrin. Now, you all know fibrin. Fibrin is a superglue that enables formation of the clot, and it attaches itself to the platelet plug and fastens it to the blood vessel wall. It's very important for us, but it's really not, absolutely not needed for no reason. We need it only to stabilize the platelet plug. Fibrinogen is very safe. If you do not make useless fibrin, you do not make any clots. No fibrin, no clots. What heparin does, heparin, it prevents coagulation. How does it prevent coagulation? It prevents, not only does it prevent coagulation, but it also prevents already formed clots from becoming larger. How does it do it? Well, heparin increases activity of another enzyme called antithrombin, antithrombin 3 in particular, but and it increases its activity 2 to 4,000 fold, so 4,000 times. So antithrombin does its job 2,000 to 4,000 times better. And what does antithrombin do? Look at the name, anti what? Antithrombin. Here you go. Antithrombin. It doesn't let thrombin act on fibrinogen and make fibrin. Thrombin doesn't make fibrin from fibrinogen, and so fibrin is not formed. If there is no fibrin, there is no clot. If there is no clot, you won't have pulmonary emboli. Why do we care about pulmonary emboli? Once again, what is a pulmonary embolus? It's a clot that travels to the pulmonary arterial circulation and obstructs the arterial blood flow through the lungs. Why is it even an issue? Well, so it happens, unfortunately, that it's also the leading cause, number one cause of maternal mortality. Anything that is number one, for example, atrial fibrillation is the most common arrhythmia and cause of arrhythmia / dysrhythmia in clinical practice. You will get tons of these questions on your NCLEX, your core classes, and in real life, you're always going to be seeing it. These are number one, most common. Master them, study them cold. Most common, leading cause of maternal mortality, pulmonary emboli. So, why is it that maternal mortality is so high due to pulmonary embolism? Well, think about it. Pregnancy is an example where all of the Virchow's triad requirements, so as to say, the risk factors, are fulfilled. One of them is stasis, venous stasis. Another one is easy clotting, hypercoagulability. And the other one is the damage to the lining of the blood vessel in contact with blood, the endothelium. So, let's go over them in a little bit of a detail. Pregnancy, what it does is that increases risk and thus weakens valve leaflets in veins. I'll remind you that veins have valves like so, preventing blood being pulled down by gravity. This is your foot, vein valves are like so. They prevent blood from coming back to the dependent areas. Now, what if you were to dilate those veins? Valves are still there, but now there is space between them, and so blood can start pooling in the legs, in the veins, in the feet, and that's a vicious cycle. It keeps on worsening as it progresses. So pregnancy weakens those valve leaflets and veins, and this causes a thing called venous insufficiency, i.e., pooling of blood. And so it does affect both the deep and the superficial veins, but you know that what we care about here are the deep veins, because DVTs are a problem if you have thrombi, if you have stasis. Venous insufficiency results in stasis, resulting in a higher risk of DVT formation. And so tissue edema that comes along with that, that's more superficial veins. And obviously, it's the least of your concerns if the patient is shooting DVTs. What else can cause DVTs? Well, hypercoagulability is seen in increased estrogen, which is also a part of the deal in pregnancy. Mothers who are pregnant, maternal mortality is also high because estrogen is increased. 50-fold elevation of estrogen, up to 1,000-fold elevation in a kind of an estrogen called estriol produced in the placenta. What else increases estrogen? Hormonal contraception increases estrogen, and so you know those warning labels where they say do take the OCP, oral contraceptive pills, at your own risk, because hormone, you know, there is an increased risk of DVTs. Cancer also increases risk of forming DVTs, because cancers often produce procoagulants, so blood clots easier. Now, when does blood not clot easily as in hypercoagulability, but just doesn't move as much? Well, if someone has an orthopedic cast, is wearing an orthopedic cast, that's called immobilization. Someone is very much overweight, BMI more than 40, that's morbid obesity. Someone is a little bit older, age, but also if you think about it, when the heart does not contract properly. In atrial fibrillation, there is no coordinated atrial systole. Blood does not contract, heart does not contract around blood that it surrounds. It kind of like flimmers a little bit, and blood is not pushed away from that chamber, and so blood stasis is seen. There is no real contraction, and so there is an increased risk of clotting. And so if it's the clot that forms in the left side of the heart, the left atrium, you may see a stroke. And if it's the clot that forms in the right atrium, the right side of the heart, you may see a pulmonary embolus.